Welcome to Pharmacology Insights, where we break down complex pharmacology into simple, easy-to-understand concepts. Parkinson's disease is the second most common neurodegenerative disorder worldwide. It is characterized by a combination of motor symptoms such as tremors, rigidity, and bradykinesia or slowness of movement. A hallmark feature of Parkinson's disease is the accumulation of misfolded alpha-synuclein proteins inside neurons. These abnormal proteins clump together to form Lewy bodies, the pathological signature of the disease. Beyond forming static aggregates, misfolded alpha-synuclein can develop into toxic oligomers and fibrils that behave like prion, spreading from one neuron to another, and propagating the formation of new protein clumps across the brain. The misfolded proteins interfere with multiple cellular processes. They disrupt mitochondrial function, impair protein degradation pathways, like autophagy and lysosomal clearance, and impair synaptic function and neurotransmitter release. The resulting cellular stress leads to oxidative damage, inflammation, and ultimately cell death, especially dopamine-producing neurons. The motor symptoms of Parkinson's arise primarily from the loss of dopamine-producing neurons in a midbrain region, called the substantia nigra pars compacta. These neurons send projections to the striatum, forming the nigrostriatal pathway, which plays a key role in controlling voluntary movements. Dopamine acts as a key modulator in the motor control system. It stimulates the direct pathway to facilitate movement, while inhibiting the indirect pathway to prevent excessive suppression of movement. As Parkinson's disease progresses, these dopamine-producing neurons degenerate, leading to a dopamine deficiency in the striatum. With reduced dopamine signaling, the direct pathway becomes inactive, making it harder to initiate movement, while the indirect pathway becomes overactive, leading to excessive inhibition of movement. This imbalance results in the characteristic motor impairments seen in Parkinson's disease. Despite decades of research, Parkinson's remains incurable, with current treatment focused on symptom management. Most treatment aim to restore or mimic dopamine. Let's briefly look at what treatments are available today. The gold standard therapy is L-Dopa, a precursor to dopamine that can cross the blood-brain barrier. It's often combined with carbidopa or benserazide to prevent its premature breakdown before reaching the brain. Over time, though, L-Dopa's effectiveness diminishes, and side effects like involuntary movements emerge. Other drugs used in Parkinson's disease include the monoamine oxidase B inhibitors, like selegiline and razagiline. These drugs help slow the breakdown of dopamine, allowing it to remain active for longer. Catechol-methyltransferase or COMT inhibitors, like entacapone and opicapone, work by prolonging the effect of L-Dopa, helping smooth out motor fluctuations. And then there are dopamine agonists, including pramipexole and ropinirole, which mimic dopamine by directly stimulating its receptors in the brain. While these treatments manage symptoms, none halt disease progression. And long-term use can bring motor fluctuations, psychiatric effects, and reduced quality of life. So, what hope lies in the pipeline? We'll cover emerging treatments for Parkinson's disease in another episode. And that's it for today's pharmacology video. If you enjoyed this video, please give it a thumbs up and subscribe to the channel for more pharmacology content.